Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today our topic of discussion is about pachychoroid spectrum. Yes, a phenomena which has done a paradigm shift in retinal management diseases. And in order to discuss about this pachychoroid spectrum, we have requested Dr. Pasquale Vigiano, a leading researcher from University of Bari, Aldomoro, Italy. Dr. Pasquale has done extensive research work on age-related macular degeneration, diabetic retinopathy, and particularly about pachychoroid spectrum. He is a leading voice on this specific topic. He has done a lot of research, and his articles have been published in indexed journals internationally. And we are thankful to him that in spite of his very busy schedule, and especially he has returned recently from Euroretina, he has given our time, he has accepted our invitation to educate our audience about this very challenging field of pachychoroid spectrum, because it is very challenging to differentiate different diseases and then to treat accordingly. So without further delay, I will request Dr. Pasquale to please present his talk.
Good afternoon, everyone, and thank you for the opportunity. For me, it's an honor to be here and to present this important pachychoroid spectrum disease in this fantastic YouTube channel. So I would like to start with the pachychoroid spectrum disease is defined as a group of clinical entities characterized by the same pathological process based on choroidal congestion and hyperpermeability. So, but it's important to understand every single factor to analyze. In particular, what are the typical structural anomalies typical of pachychoroid spectrum disease? So when we look at the structural OCT, it's important to evaluate the presence of dilated outer choroidal vessel or the presence of inner choroidal thinning, subtler layer and chorocapillaris, and the presence of pachyjuice above the pachy vessel, the dilatation of Haller layer. So these are the typical clinical characteristics that you may appreciate in structural OCT, but they are often linked with choroidal hyperpermeability that we may evaluate with indocyanine green angiography. But we know different risk factor of pachychoroid spectrum disease. In particular, in this fantastic paper, you may appreciate the different incidence and risk factors as male gender or age, typical 30-50 years peak incidence, Asian ethnicity, or type A personality and high stress and obstructive sleep apnea, irregular sleep patterns. It's typical of pachychoroid spectrum disease, of patient affected by pachychoroid spectrum disease, or systemic corticosteroid use. It's another important risk factor. But we know also lifestyle factors as excessive caffeine consumption and or alcohol use, or genetic factors as family history of central serous chorioretinopathy. But what are the pathophysiology mechanism typical of pachychoroid spectrum disease? So in the last years, many authors tried to explain the pathogenic theory of pachychoroid spectrum disease. The first theory is the classical pathogenic theory, characterized by the presence of Haller dilatation with mechanical compression of the inner choroid, the presence of ischemia, or in particular of chorocapillaris, and then RP dysfunction with the presence of subretinal fluid. And this mechanical compression is typical also in development of neovascularization following central serous chororetinopathy. So in this our paper, we found that the patients affected by a thinning of chorocapillaris and subtler layer are characterized by the presence of neovascularization. We found a difference in patients affected by central serous chororetinopathy complicated versus non-complicated by macular neovascularization. And the progressive choroidal thinning may be a key feature of neovascular transformation. So, but in the last years, many authors, very experts in this field, in this pachychoroidal spectrum disease, develop the two-height mechanism concept. This model suggests that two distinct pathophysiologies process must occur for the full expression of disease. In particular, we know two different it. First, these are anatomical predisposition as thick sclera or short axial length and asymmetric vortex venous drainage. But pay attention, because this predisposition may not alone lead to disease manifestation. It's important to understand the second the triggering factors, as for example, steroid exposure or physiological stress and hormonal fluctuations, autonomic nervous system imbalance, sleep disturbance, and metabolic disorders. And this through it mechanism explains why not all individuals with anatomical pachychoroid features develop a clinical disease, and why disease manifestation can be episodic or fluctuating. So another important concept that many authors suggested in these years are choroidal venous overload theory. This new theory suggests that the abnormalities in the choroidal venous drainage play a crucial role in pachychoroid spectrum disease development. We know very well that the choroid has numerous parallel vessels that drain directly into the vortex veins. And the passage of these veins through the sclera acts as a Starling resistor, helping maintain constant outflow pressure. And the alteration of the sclera, the thickening sclera with this mechanism of Starling resistance, cause the presence of dilated choroidal veins, presence of intervortex anastomosis, and alteration in a chorocapillaris structure. And we found this result in this fantastic paper when we analyzed the patient affected by pachychoroid neovasculopathy versus patient affected by exudative age-related macular degeneration. So finally, the most important concept of pathophysiologists, we decided to describe these multi-it models, so a combination of this pathophysiologist mechanism that I explained before. In particular, risk factor assessment is the first step to evaluate the first it at the second it, to obtain multimodal imaging to better understand the pachychoroid spectrum disease, in particular CGA and structural OCT, and after diagnosis determination with classification and management approach. But we know different clinical entities of pachychoroid spectrum disease, and it's important to perform a multimodal imaging to better understand this condition. But it's very important, the multimodal imaging, to differentiate the pachychoroid spectrum disease from other chororetinal conditions, in particular age-related macular degeneration. I would like to start to show you the pachychoroid pigment epitheliopathy versus intermediate AMD. For example, we know that in intermediate AMD, we know the drusen characterized by normal thickness, normal choroidal thickness, with this hemispherical elevation of RPE, usually present in both eyes, or the presence of reticular pseudodrusen is typical of intermediate AMD with thinning sclera, and it's important, and thinning choroidal thickness. It's very important to look at the choroidal thickness and choroidal vessel dilatation. While in pachychoroid pigment epitheliopathy, you may appreciate the dilatation of choroidal vessel, in particular in Haller layer, in this patient in both eye, with the presence of choroidal cavernoma and presence of pachydrusen. Another important exam of multimodal imaging is structural unfast OCT, where you may appreciate the presence of a dilatation of choroidal vessel. But it's important to evaluate the patient with neovascularization and to differentiate neovascular AMD to pachychoroid neovasculopathy. This is a patient affected by type 1 macular neovascularization in the left eye that you may appreciate with OCT angiography, but it's important to look at the fellow eye. In the right eye, you may appreciate the presence of drusen, the normal choroidal thickness, and this is a patient affected by type 1 macular neovascularization, but in neovascular age-related macular degeneration. And this is a patient with a similar age, with a type 1 macular neovascularization, but in this patient, we may appreciate the shallow RPE, irregular PD, and the presence of the Haller dilatation of choroidal vessel, and in this case, we have pachychoroid neovasculopathy, and even in this case, it's important to look at the fellow eye. The fellow eye of this patient is affected by pachydrusen and pachyvessel. In pachychoroid neovasculopathy, patient with no evidence of age-related macular degeneration or other causes of degeneration develop type 1 macular neovascularization, but in this case, it's very important to obtain exam as ICGA to evaluate the hyperpermeability of choroidal layer. And you may appreciate the difference also in unfast structural OCT. You may appreciate the dilatation of choroidal vessel in the left image, in the right image, normal choroidal layer, normal choroidal vessel, typical of age-related macular degeneration. Another important dissimilarity between these two conditions is the presence of VEGF in neovascular AMD. The VEGF is higher compared to the pachychoroid neovasculopathy. For this reason, pachychoroid neovasculopathy seems to respond to anti-VEGF better compared to the neovascular AMD. Another important condition that we may appreciate in age-related macular degeneration and in pachychoroid spectrum disease is the polypoidal choroidal vasculopathy, as known aneurysmal type 1 neovascularization, characterized by the presence of sub-RPE or subretinal hemorrhage and fluid accumulation. But we know different structural OCT biomarkers that we may appreciate when look at this pathology. In particular, the presence of a sharp picked pad. It's typical of polypoidal choroidal vasculopathy, or the presence of a sub-RP ring-like lesion that you may appreciate in this structural OCT, or the presence of a multilobular pad. It's typical, often linked to massive subretinal fluid. And another important structural OCT biomarkers is double layer sign that could hide the branching vascular network. Very important, the branching vascular network in their patients that that could because the growth of non-exudative is associated with a developed neovascularization, is a developed recurrence of this condition, this polypoidal choroidal vasculopathy is a condition associated with or normal choroidal thickness or increased choroidal thickness associated with the Pachychoroidal Spectrum disease. And in this image, you may appreciate the difference of choroidal thickness, but in particular, if you look at autofluorescence, you may appreciate in the right image the presence of RP dysfunction in macular region, but also optic nerve. So another important condition is acquired vitelliform maculopathy. We know that acquired vitelliform maculopathy is an accumulation of yellowish subretinal material, often associated with the presence of intermediate MD. So, for example, in this patient associated with the reticular pseudodrusen, and you may appreciate the presence of reticular pseudodrusen, but sometimes it could be associated with the RP dysfunction and the pachychoroid condition, and this is very important to differentiate these two conditions. Finally, the last condition that we analyze is the peripapillary pachychoroid syndrome. Is a distinct variant of pachychoroid disease in which maximal choroidal thickness occurs close to the optic nerve rather than subfoveally, and it's important to obtain multimodal imaging to evaluate the presence of intraretinal fluid, the choroidal congestion closer to the optic nerve, and in particular the absence of neovascularization. So to conclude, it's very important to understand the treatment and the management of anti-VEGF in our diagnostic and the management approach that we proposed in our review on progress in retinal and eye research. We differentiate the non-neovascular Pachychoroidal spectrum disease, and it's important to understand the condition, to understand the pachychoroid, to differentiate between central serous choroidetinopathy, pachychoroid pigment epitheliopathy, and peripapillary pachychoroid syndrome. When you see the subretinal fluid or intraretinal fluid, PDT is the first line therapy for persistent and recurrent fluid, or second line as subthreshold micropulse laser and antagonist of mineral corticoid receptor as eplerenone. While neovascular form, the first therapy is anti-VEGF therapy, but in some case you have to consider to associate anti-VEGF with photodynamic therapy. It's important to differentiate central serous choroidetinopathy complicated by macular neovascularization from pachychoroid neovasculopathy. The treatment is different. In conclusion, correct imaging is essential in this condition. Uniform imaging based international consensus on pachychoroid spectrum disease is needed. It's important to understand this condition, to understand the pathophysiology mechanism, because understanding the pathophysiology, we obtain a right therapy in these patients. Thank you for your kind attention.
Well, it was a very interesting talk, and Dr. Pasquale, you have explained in detail all these features about pachychoroid spectrum. A few things coming in my mind is, first thing is about the pathophysiological mechanism. What do you think? What is the most important pathophysiological mechanism which is involved in these diseases? And secondly, we are nowadays quite dependent upon OCT and OCT angio. Which is the most important factors which help us? I'm talking from the perspective of a general ophthalmologist. Which are the most important to differentiate it from other chorioretinal diseases?
Thank you for your question. It's a very interesting question. So about the pathophysiological mechanism, so while the classical mechanical compression theory has historical importance, I believe that choroidal overload theory represents the most complete current framework. And the evidence for intervortex anastomosis, dilated choroidal veins, and similarities to systemic venous insufficiency provides a unifying explanation. We proposed a multi-hit models for this reason. The first hit associated with the second hit associated with the choroidal overload theory are very important. This explains why not everyone with thick choroid develops clinical disease. About the key structural OCT and OCT findings that help us to differentiate pachychoroid spectrum disease from other choroidal condition. I think that the diagnostic triad of pachychoroid is the dilated choroidal vessel, in particular of the Haller layer, the thinning of the subtler choriocapillaris complex, the presence of pachytrusion on structural OCT, and the most important exams is remains the ICGA to evaluate the choroidal hyperpermeability, to differentiate pachychoroid spectrum disease from other choroidal condition. In age-related macular degeneration, we did not observe the presence of the presence of hyperpermeability. And
Well, Dr. Vijayanam, when we look at your studies, you have done extensive work on this particular topic of pachychoroid spectrum. And when we look at your research, how important is measurement of choriocapillaris blood flow measurement? Is it very important? And secondly, when we talk about the choroidal thickness, is it relevant in the management of these diseases?
Thank you for your question. So about choriocapillaris OCT angiography as revolutionated our understanding by revealing choriocapillaris flow impairment, in our review, we analyzed the presence of the use of OCT angiography and the evaluation of choriocapillaris in this patient. Actually, every single condition of pachychoroid spectrum disease is characterized by choriocapillaris flow deficit with dysfunction of perfusion of this layer, this has shifted our focus from just structural to functional assessment, helping predict which eyes might develop a neovascularization or develop the other condition. So about the choroidal thickness, now in this moment, what matters is the architectural disruption and the flow patterns. In central serous chorioretinopathy, for example, with neovascularization, OCT angiography is the most critical examination to evaluate the presence or absence of neovascularization. It's important also to drive the treatment decision between anti-VEGF or PDT or combination of these two treatments. I don't hear you.
We have seen many treatment options, anti-VEGF, photodynamic therapy. In your experience, what is the most effective treatment in these pachychoroid spectrum diseases? How do you see the future of the management when we are having more and more imaging modalities available, OCT, OCTA, different coming? How do you see the future of this pachychoroid spectrum management?
So treatment should be tailored to the specific entity and stage. For example, for acute central serous choroidiopathy, observation often suffices. For chronic or recurrent central serous choroidiopathy, photodynamic therapy remains the gold standard through subthreshold micropulse layer, and the Pleuronone offer good alternatives. For neovascular complication, anti-VEGF is the first line, often combined with photodynamic therapy, but the key is addressing both the neovascularization and underlying pachychoroidal process. So about the future, I think that AI and artificial intelligence assisted diagnosis using multimodal imaging patterns, novel therapeutic targeting, venous drainage abnormalities, and personalized medicine based on genetic risk profiles is the future. We are also exploring the different alternatives as photobiomodulation and sustained release drug delivery system. But now, in this moment, it's important to understand the pathology, the clinical entities, evaluate the neovascular or not neovascular, and after the ultimate goal is moving from reactive treatment to preventive intervention in high risk individuals.
Well, Dr. Vijano, it was a very informative talk, and I think you have answered the question in detail for our audience, and it will be very beneficial for us because sometimes these pachychoroid diseases present asymptomatic, but if not properly treated, they can lead to the severe vision loss. So they have to be respected, and proper diagnosis very important. So I want to thank you on behalf of my audience, and we are looking forward to more lectures from you to get benefit from your knowledge and experience. I want to thank you on behalf of our all audience. Thank you, Dr. Vijayan.
Thank you so much.